A very good day to Prof. Jose, Dr. Ranjit, and our fellow classmates. Today, me and my group members, Shahira, Akila, and Rashida, will be presenting on our seminar topic on skin lesions. So before we start, let's go through the learning outcomes. So the first is to classify the mucocutaneous lesions which affect the skin and oral mucosa. And the second is to differentiate clinical and histopathological features of mucocutaneous lesions. So for classification, there is no universally accepted classification of these dermatologic diseases. However, several broad groups of diseases may be separated out on the basis of the nature of the disease process or on the nature of the lesion itself. So we divided the mucocutaneous lesions into genodermatosis, vesicular-based lesions, and ulcerative or erosive lesions. So under genodermatosis, there are ectodermal dysplasia, white sponge nevus, Darier's disease, Peutz-Jeghers syndrome, hereditary hemorrhagic telangiectasia, Ehlers-Danlos syndrome, epidermolysis bullosa, and erythema multiforme. For vesicular-based lesion, it can be further divided into immunologically mediated and hereditary disease. So under immunologically mediated, there are pemphigus vulgaris, mucous membrane pemphigoid, bullous pemphigoid, lichen planus, paraneoplastic pemphigus, and erythema multiforme. Under hereditary disease, there are Darier's disease and epidermolysis bullosa. For ulcerative and erosive lesion, there is lichen planus. Vesicular-based lesion can also be divided based on the blister formation. So the first is intraepithelial blister formation. There is pemphigus vulgaris, Darier's disease, and epidermolysis bullosa simplex. For subepithelial blister formation, there are mucous membrane pemphigoid, bullous pemphigoid, junctional epidermolysis bullosa, and dystrophic epidermolysis bullosa. For occasional subepithelial blister formation occupied by basal cell destruction, there is lichen planus. And for intraepithelial and/or subepithelial blister formation, there are erythema multiforme and paraneoplastic pemphigus. So the first lesion is ectodermal dysplasia. So ectodermal dysplasia is a group of inherited conditions in which two or more ectodermally derived anatomic structures fail to develop, and these tissues primarily are the skin, hair, nails, eccrine glands, and teeth. And the current classification of ectodermal dysplasia is based on clinical features. And to date, more than 150 distinctive syndromes have been described, but the most common syndromes within this group are hypohidrotic and hidrotic ectodermal dysplasia. So hypohidrotic ectodermal dysplasia is the most common phenotype in this group, and it is usually inherited as an X-linked recessive trait. It is characterized by several defects which are hypohidrosis, hypotrichosis, and hypodontia. So, individuals affected by ectodermal dysplasia have abnormalities in different structures. So, in ectodermal dysplasia, the sweat glands are reduced in number or absent, which causes hypohidrosis, which is the lack or diminishing in sweating. And due to this, they also typically display heat intolerance and hyperpyrexia. Other signs of these disorders include fine sparse hair, reduced density of eyebrow and eyelash hair. The periocular skin may also show fine wrinkling with hyperpigmentation. And as you can see in the picture, the man had a fine sparse hair, reduced density of eyebrows and eyelash hair, and also the periocular skin show the hyperpigmentation. They are also characterized by frontal bossing, depressed nasal bridge, and protuberant lips. And as you can see in the boy, there is frontal bossing, depressed nasal bridge, and protuberant lips. So coming to the oral manifestations, because the salivary glands are ectodermally derived, these glands may be hypoplastic or absent, and the patients may exhibit varying degrees of xerostomia. And the teeth are usually markedly reduced in number, which are oligodontia or hypodontia, and where some teeth are present, they are commonly truncated or cone-shaped. As you can see in the picture, there it shows hypodontia, and when the teeth present, there is cone-shaped. So complete lack of tooth development, which is the anodontia, has also been reported, but this appears to be uncommon. And in addition, the palatal arch is frequently high and a cleft palate may be present. Next is the histopathologic features. So the skin histopathology documents the reduction in the number of sweat glands, hair follicles, and sebaceous glands associated with the different syndromes. In hypohidrotic ectodermal dysplasia, the epidermis is thin and flattened, eccrine sweat glands are few or poorly developed or are very rudimentary. Next is the white sponge nevus. So white sponge nevus is a relatively rare genodermatosis that is inherited as an autosomal dominant trait, displaying a high degree of penetrance and variable expressivity. And the etiology for white sponge nevus is mutation of keratin genes, either keratin 4 or keratin 13, causing defect in the normal keratinizations of the oral mucosa. So the clinical features for white sponge nevus. The lesions of white sponge nevus usually appear at birth or in early childhood, but sometimes the conditions develop during adolescence. So for the most common site is at the buccal mucosa bilaterally. For other common intraoral sites include the ventral tongue, labial mucosa, soft palate, alveolar mucosa, and floor of the mouth. For extramucosal sites such as the nasal, esophageal, laryngeal, and anogenital mucosa appear to be less commonly affected. The lesion appears as symmetrically thickened, white corrugated or velvety diffuse black, affecting the buccal mucosa bilaterally in most instances, and patients are usually asymptomatic. As you can see in the both of the picture, it is a diffuse thickened white plaques of the buccal mucosa, and the lesions on the right picture is more corrugated. So moving on to the histopathologic features, the microscopic features of white sponge nevus usually show prominent hyperparakeratosis with marked acanthosis and with clearing of the cytoplasms of the cells in the spinous layer. And these are the common features for the white sponge nevus. In some instances, an eosinophilic condensation is noted in the perinuclear region of the cells in the superficial layers of the epithelium. It is a feature which is unique to the white sponge nevus. And ultrastructurally, this condensed material can be identified as tangled masses of keratin tonofilaments. So the photomicrograph on the left shows a prominent hyperparakeratosis with marked thickening, and which is the acanthosis, and vacuolizations of the spinous cell layer. And the photomicrograph on the right shows vacuolation of the cytoplasm of the cells of the spinous layer. See there is vacuolations of the cytoplasm of the cells of the spinous layer. And perinuclear condensation, keratin tonofilaments can also be observed in some cells. Next is the Darier's disease. So Darier's disease is an uncommon genodermatosis with striking skin involvement and relatively subtle oral mucosal lesions. This condition is inherited as an autosomal dominant trait, having a high degree of penetrance and variable expressivity. A lack of cohesion among the surface epithelial cells characterize diseases, and mutation of the gene, which is identified as ATP2A2, has been identified as the cause for abnormal desmosomal organizations of epithelial cells. So for clinical features, patients with Darier's disease have numerous erythematous, often pruritic papules on the skin of the trunk and the scalp that develop during the first or second decades of life. As you can see in the picture at the top, there is numerous papules all over the skin of the trunk, and the bottom picture is the close-up picture of the above lesions. And also, an accumulation of keratin producing a rough texture may be seen in association with the lesions, and a foul odor may be present as a result of bacterial degradations of the keratin. And the process generally becomes worse during the summer months. It is either because of sensitivity of some patients to UV light or because increased heat which results in sweating, which induces more epithelial clefting. And the palms and soles often exhibit peaks and keratosis, while the nails show longitudinal lines, ridges, or painful splits. So for oral manifestations, the oral lesions are typically asymptomatic and are discovered on routine examination. They consist of multiple, normal-colored or white, flat-top papules that, if numerous enough to be confirmed, it will result in a cobblestone mucosal appearance. And these lesions affect the hard palate and alveolar mucosa primarily, although the buccal mucosa or tongue may be occasionally involved. And if the palatal lesions are prominent, then the condition may resemble inflammatory papillary hyperplasia or nicotine stomatitis. As you can see in the picture, the oral mucosa shows the multiple white papules on the palate. Next is the histopathologic features of Darier's disease. So the microscopic examinations of the cutaneous or mucosal lesions shows a dyskeratotic process, which is characterized by central keratin plaque, the ovalized epithelium exhibiting a suprabasilar cleft. And this suprabasilar cleft or intraepithelial clefting is also known as acantholysis. In addition, the epithelial rheator ridges associated with the lesions appear narrow, elongated, and test tube shaped. And closer inspection of the epithelium reveals varying numbers of two types of dyskeratotic cells called cork rounds or grains. So the photomicrograph on the top left, you can observe there is central keratin plugging. Underneath it, there is epithelium with a suprabasilar cleft. And the rheator ridges also appear elongated and narrow. And the same goes to the photomicrograph on the right. And the photomicrograph on the bottom left shows a clearer picture of suprabasilar or intraepithelial clefting.
My name is Shahira, and now I'm going to be talking about Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is an autosomal dominant inherited disorder. So as you can see, on the first and second picture, it is characterized by freckle-like lesions on the hand and around the mouth, and also the oral mucosa. And on the third picture, intestinal polyposis can also be seen. Patients are predisposed to developing cancers of the GI tract, including the pancreas and luminal organs, and also the females and males' reproductive tracts. The syndrome is caused by the mutation of the STK11 gene. The clinical features seen in Peutz-Jeghers syndrome is that the patients usually have a positive family history of Peutz-Jeghers syndrome. The occurrence of cases in males and females are equal. The average age of diagnosis is 23 in men and 26 in females. The presenting complaints are usually repeated bouts of abdominal pain, unexplained intestinal bleeding, and also menstrual irregularities. Other than that, pigmentation can also be seen, which is usually present on the fingers and toes, on the hands and feet, oral and perioral areas. Lesions resemble freckles, but they do not wax and wane with sun exposure. Pigmentation may fade after puberty. Another clinical feature is intestinal polyps, where jejunum and ileum are most commonly affected. Patients also have problems with intestinal obstruction because of intussusception, which is a condition where one segment of the intestine telescopes inside of another, causing an intestinal blockage. This is seen on the picture shown on the right. This is often caused by polyps. The oral manifestation seen in Peutz-Jeghers syndrome is 1 to 4 mm brown to blue-gray macules, primarily affecting the vermilion zone, labial and buccal mucosa, and the tongue. Other manifestation includes precocious puberty, which is puberty occurring at an unusually early age, prolapse of tissue from the rectum, rectal polyp, testicular mass, and gynecomastia. Histopathological features of the gastrointestinal polyps represent as benign overgrowth of intestinal glandular epithelium supported by a core of smooth muscle. Epithelial atypia is not usually a prominent feature, unlike the polyps of Gardner syndrome. For pigmented cutaneous lesions, there's slight acanthosis of the epithelium with elongation of rete ridges. There's no apparent increase in melanocyte number, but the dendritic processes of the melanocytes are elongated. Now I will be presenting about hereditary hemorrhagic telangiectasia, which is also known as Osler-Weber-Rendu syndrome. Hereditary hemorrhagic telangiectasia is an uncommon mucocutaneous disorder. We should be familiar with this disorder because the oral lesions are often the most dramatic and easily identified component of the syndrome. So there are two types of hereditary hemorrhagic telangiectasia, which is the HHT1 and HHT2. HHT1 is caused by a mutation of endoglin gene, whereas HHT2 is caused by a mutation of activin receptor-like kinase 1 gene. The proteins produced by these genes play a role in the blood vessel wall integrity. Therefore, in both types of HHT, numerous vascular hematomas develop, affecting the skin and also the mucosa. Diagnosis of hereditary hemorrhagic telangiectasia can be made if patient has three of the following four criteria. 1. Recurrent spontaneous epistaxis. 2. Telangiectasia of the mucosa and the skin. 3. Arteriovenous malformation involving the lungs, liver, or central nervous system. And finally, 4. When the patient has family history of hereditary hemorrhagic telangiectasia. Nasal and oropharyngeal mucosa exhibit scattered red papules which blanch when diascopy test is done. The first and second pictures show the scattered red papules, and the third picture shows diascopy test being done. Diascopy is a test of blanchability performed by applying pressure with finger or glass slide and observing for color changes. Lesions such as hereditary hemorrhagic telangiectasia will blanch, indicating that the red color is due to the blood contained within the blood vessels. But if there is no blanching, it indicates that the blood is outside the vessels. Gastrointestinal telangiectasias can also be seen. They have a tendency to rupture, which may cause significant blood loss, and chronic iron deficiency anemia may develop. Arteriovenous fistulas may develop in mostly lungs, liver, and brain. Pulmonary arteriovenous malformations seen in this picture can predispose patients to the development of brain abscesses because clots or bacteria in the lung circulation that would normally get entrapped in the small capillaries can pass through the arteriovenous malformation to the blood vessels of the brain and cause brain abscess. CREST syndrome must be considered for differential diagnosis because telangiectasia in CREST syndrome are similar to those seen in hereditary hemorrhagic telangiectasia. In these cases, serologic studies for identifying anticentromeres antibodies often help to distinguish between the CREST syndrome and hereditary hemorrhagic telangiectasia because these antibodies would be present only in CREST syndrome. Histopathologic features of hereditary hemorrhagic telangiectasia shows superficially located collection of thin-walled vascular spaces that contain erythrocytes. Next, I'll be talking about Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a group of inherited disorder of connective tissue due to the defect of collagen synthesis. Ehlers-Danlos syndrome may occur due to the following: mutation in the gene coding for collagen, or deficiency of collagen processing enzymes such as lysyl hydroxylase and procollagen peptidase. The clinical manifestations vary with the type of Ehlers-Danlos syndrome. The typical clinical findings are hypermobility of joints, seen in the second picture, easy bruisability, and marked elasticity of skin, seen in the first picture. An unusual healing response often occurs with relative minor injury to the skin and is termed papyraceous scarring because it resembles crumpled cigarette paper. This is seen on the third picture. This table shows the different types of Ehlers-Danlos syndrome. The pattern of inheritance and the clinical manifestation vary with the type of Ehlers-Danlos syndrome being examined. About 80% of patients have the classical type in either the mild or severe form. Classical type exhibits the typical clinical findings such as hyperextensible skin, easy bruising, and hypermobile joints. The mild form of classical type of Ehlers-Danlos syndrome exhibits a less severe clinical manifestation. Hypermobility type shows joint hypermobility but no evidence of unusual scarring. The life expectancy of patients with the vascular type of Ehlers-Danlos syndrome is greatly reduced because of the tendency for the aortic aneurysm formation and rupture. For type 8, it is a rare form of Ehlers-Danlos syndrome, and it has a dental manifestation as a hallmark feature with patients showing marked periodontal disease at a relatively early age. The oral manifestation of Ehlers-Danlos syndrome includes the Gorlin sign, which is the ability of the patient to touch the tip of their nose with the tongue. The oral mucosa is also fragile, where it can lead to easy bruising and bleeding. Early onset of periodontal defects can also be seen. Hypermobile temporomandibular joint with high incidence of recurrent dislocation can also be seen. And as for the dentition, there's lack of normal scalloping of the dentino-enamel junction. There's also formation of irregular dentine. Pulp stones are also seen, which seems to occur more commonly in the classical type of Ehlers-Danlos syndrome. And there's higher incidence of enamel and dental fractures. Malformed and stunted tooth roots may also occur. Now I'm going to be talking about epidermolysis bullosa. Epidermolysis bullosa is a group of inherited blistering mucocutaneous disorder with specific defect in the attachment mechanism of epithelial cells, either to each other or to the underlying connective tissue. Depending on the defective mechanism of cellular cohesion, there are four broad categories: epidermolysis bullosa simplex, junctional epidermolysis bullosa, dystrophic epidermolysis bullosa, and Kindler syndrome. Kindler syndrome is the most recently characterized pattern of this group of disorders. The etiology of epidermolysis bullosa differs with each type. Epidermolysis bullosa simplex is caused by the mutation in the genes encoding keratin 5 and keratin 14. Due to this, an intraepithelial skin separation is seen. By looking at the picture on the right, it'll help you to understand how the mutations in the gene encoding keratin 5 and 14 cause intraepithelial blister formation. Junctional EB is caused by the mutation of genes encoding laminin 5, type 17 collagen, or alpha 6 beta 4 integrin. This causes skin separation in lamina lucida, or central basement membrane zone. Dystrophic EB is caused by the mutation of gene encoding type 7 collagen. This causes sublamina densa basement membrane zone separation. Epidermolysis bullosa simplex manifests at birth or shortly thereafter. It is characterized by the formation of vesicles and bullae, chiefly on the hands and feet at the sites of friction or trauma. The blisters heal within 2 to 10 days without scarring or permanent pigmentation. The disease appears to improve at puberty, and there's a good prognosis. Oral manifestations include mucosal involvement, and teeth are not affected. 3 criteria have been established for the diagnosis of junctional epidermolysis bullosa, which are onset at birth, absence of scarring, milia or pigmentation, and death within 3 months of age. Many cases results in death at birth because of the significant sloughing of the skin during the passage through the birth canal. Bullae are similar to those seen in dystrophic recessive type, except that they commonly develop spontaneously, and sheets of skin may usually be shed. Oral manifestations include oral bullae, which are frequently very extensive and produce serious feeding problems. Epidermolysis bullosa dystrophic dominant type is usually not life-threatening. Vesicles of bullae, which are seen early in life, develop on areas exposed to low-grade chronic trauma, such as the knuckles or knees. This is seen on the picture on the right-hand side of the slide. The bullae ruptures resulting in erosions or ulceration that heal with scarring. In the process, fingernails may be lost. Oral manifestations include gingival erythema and tenderness, gingival recession, and also reduction in the depth of buccal vestibule. These features are seen at the bottom right-hand side picture. Generalized recessive dystrophic epidermolysis bullosa represent one of the most debilitating forms of the disease. Vesicles and bullae form even with minor trauma. If patient manages to survive into the second decade, then hand function is often greatly diminished because of the repeated episodes of cutaneous breakdown and healing with scarring, resulting in a fusion of fingers into a mitten-like deformity. The picture on the left shows the mitten-like deformity. Oral manifestation includes bulla and vesicles which form in the mucosa. Even with a soft diet, it will cause repeated cycles of breakdown and scarring, causing microstomia and ankyloglossia. The picture on the right shows microstomia. Stricture of esophagus can also be seen, and this is also due to the repeated cycles of mucosal injury and scarring. Because soft diet is highly carcinogenic, caries is common at an early age. Histopathological features of epidermolysis bullosa varies with the type being examined. In light microscopy, epidermolysis bullosa simplex shows intraepithelial clefting, and as for junctional EB and dystrophic EB, it shows subepithelial clefting. For electron microscopy, epidermolysis bullosa simplex shows intraepithelial clefting, and for junctional epidermolysis bullosa, it shows clefting at the level of lamina lucida of the basement membrane. Dystrophic epidermolysis bullosa shows clefting below the lamina densa of the basement membrane. The photomicrograph on the right side of the slide shows complete separation of the epithelium from the connective tissue. This is seen in the junctional form of epidermolysis bullosa.
Okay. Hi everyone, I'm Akila. Now I'll continue with erythema multiforme. Erythema multiforme is a blistering ulcerative mucocutaneous condition of unknown pathogenesis. It probably could be immunologically mediated process or caused by precipitating factors such as drugs, infections, or certain conditions. 50% of the cases are caused by preceding infections such as herpes simplex or Mycoplasma pneumoniae. Erythema multiforme can appear in two clinical forms based on its severity, which are erythema multiforme minor, the milder form, and erythema multiforme major, the severe form. It is traditionally thought to be synonymous with Stevens-Johnson syndrome and toxic epidermal necrolysis, which is also known as Lyell disease. These two diseases are considered to be severe form and could be life-threatening. However, nowadays, these two diseases are now considered as totally separated diseases from erythema multiforme. Moving on with the clinical features, it usually affects the young adults in their 20s to 30s. It has slight female predilection. It has prodromal symptoms which are 3 to 7 days. These symptoms include fever, malaise, headache, cough, and sore throat. So these symptoms will appear before the appearance of the lesion. Now I'll be talking about erythema multiforme minor. It is more common and it is the milder form. It is usually presented with skin lesions which are asymmetrical and involvement of only one mucosal site. Primarily, it involves the skin, and oral mucosa is involved about 25% of the cases. The lesion is characterized to be slightly elevated, round, dusky red patches. And the characteristic feature of this lesion is that it resembles a target. Therefore, it is called as target lesions or also known as bullseye lesions or iris lesions. Target lesion is a concentric erythematous patch with a peripheral thin zone of pallor, followed by one or more additional thin erythematous zones. It ranges in size from millimeters to centimeters, and it is more likely to be found on flexor surface of extremities, such as the palms, which can be shown in the clinical picture here, or soles. Oral manifestations of erythema multiforme begin as erythematous patches that undergo epithelial necrosis. It may evolve into large shallow erosions and ulcerations with irregular borders. Hemorrhagic crusting of vermilion zone of the lips are often seen, as shown in the clinical picture here. And the ulcerations often have a diffuse distribution, as shown in the clinical picture below here. The common site for this lesion are the lips, labial mucosa, buccal mucosa, tongue, floor of the mouth, and soft palate. Erythema multiforme major. It is more severe, and the skin lesions are more widespread, with involvement of 2 or more mucosal sites. It presented as target lesions and may evolve into bullae with necrotic centers. And the involvement of extraoral mucosal areas are conjunctival, genitourinary, and respiratory mucosa. Next is the histopathological features of erythema multiforme. There will be subepithelial or intraepithelial vesiculation in the basilar portion, as shown in the picture above here, and there will also be association of necrotic basal keratinocytes. The picture below shows mix of inflammatory infiltrate consisting of lymphocytes, neutrophils, and often eosinophils, which sometimes may be arranged in perivascular orientation, as shown in the picture here. Next is pemphigus vulgaris. Pemphigus vulgaris is the most common skin disorder. As its name, the word vulgaris comes from Latin word which means common. Apart from pemphigus vulgaris, there are 3 other types of pemphigus, with each type has distinct clinical and immunopathologic features. These are pemphigus vegetans, pemphigus erythematous, and pemphigus foliaceus. So pemphigus vulgaris is an autoimmune intraepithelial blistering disease affecting the skin and mucous membranes, and it is mediated by circulating autoantibodies directed against the keratinocyte cell surfaces. These autoantibodies are directed against the desmoglein 3 and desmoglein 1 proteins, which are the components of desmosome. When the autoantibodies attack the desmogleins, it loses attachment between the cells and the cells become separated from each other, leading to acantholysis. As a result, this will directly lead to formation of bullae or blisters. Pemphigus vulgaris is an important condition because if it's left untreated, it can result in death. And oral lesions are often the first sign of the disease, and they are the most difficult to resolve with therapy. With this reason, oral lesions has been described as the first to show and the last to go. Moving on with the clinical features, it usually affects the adults with average age of 50 years, and it has no sex predilections, and patient usually complains of oral soreness. Examination will show superficial, ragged erosions and ulcerations distributed haphazardly on the oral mucosa. So these 3 clinical pictures shown here are the examples of how oral lesions of pemphigus vulgaris can appear. The common site involved are palate, labial mucosa, buccal mucosa, ventral tongue, and gingiva. Patient will rarely report vesicle or bullae formation. It may be because of the blisters have thin and friable roof. Skin lesions will appear as flaccid vesicles and bullae that rupture quickly, leaving an erythematous denuded surface. And a characteristic feature of this lesion that helps in diagnosis is Nykolsky sign. It is when lateral pressure is applied on clinically unaffected perilesional tissue, it could induce stripping of the epithelium on a bullae formation. Next is the histopathological features of pemphigus vulgaris. There will be intraepithelial separation which is at the suprabasal layer, as shown in the picture here. And sometimes the entire superficial layers are stripped away, leaving only basal cells and resembling row of tombstones appearance. So this row of tombstones appearance can be seen on the picture below here. There will be also acantholysis and presence of rounded cells called Zank cells. And this is a diagnostic feature of pemphigus vulgaris, which they are the split cells which lose their polygonal shape and become rounded. There will also be mild to moderate chronic inflammatory cell infiltrate, which is usually seen underlying the connective tissue. For direct immunofluorescent tests, there will be demonstration of IgG or IgM antibodies and C3 in the intracellular spaces between the epithelial cells, resulting in a chicken wire pattern. This can be shown in the picture on the right side here. And for indirect immunofluorescent tests, typically will be positive in 80 to 90% of the cases, demonstrating the presence of circulating antibodies. Now, moving on with paraneoplastic pemphigoid. It is very rare and it is neoplasia-induced pemphigus. And it usually affects patients who have neoplasm, which is usually lymphoma or chronic lymphocytic leukemia. So patient will come with history of malignant lymphoreticular neoplasm or a benign lymphoproliferative disorder, multiple vesiculous lesions of skin and oral mucosa, and hemorrhagic crusting of lips are also seen, which is similar to erythema multiforme. This can be appreciated from the clinical picture below here. And the oral mucosal involvement are characterized to be multiple areas of erythema and diffuse irregular ulcerations affecting any oral mucosal surface, as shown in the picture above here. And the other mucosal site involvement includes conjunctival mucosa, which is 70% of the cases, anogenital, nasopharyngeal, esophageal, and respiratory tract mucosa. The histopathological features of paraneoplastic pemphigoid, it may be as diverse as the clinical features, but in most cases, lichenoid mucositis is seen, usually with subepithelial clefting, which is like pemphigoid, or intraepithelial clefting, which is like pemphigus. So the picture here shows both subepithelial clefting and intraepithelial clefting. For direct immunofluorescence tests, there will be weakly positive deposition of immunoreactants IgG and complement in the intercellular zones of epithelium, or a linear deposition of immunoreactants at the basement membrane zone. So that's all from me. Thank you.
Next is mucous membrane pemphigoid, also known as cicatricial pemphigoid or benign mucous membrane pemphigoid. It is a group of chronic blister mucocutaneous autoimmune disease in which the tissue-bound autoantibodies are directed against one or more components of the basement membrane, and the cicatricial word is derived from the cicatrix, which means scar, as it is because as the conjunctival mucosa is affected, it will lead to scarring and which could lead to blindness. Next is the clinical features. It usually affects the older adults in the average age of the 50 to 60 years old, and it has female predilection. Oral lesion is mostly seen, but other sites such as conjunctiva, nasal, esophageal, laryngeal, vaginal mucosa, and skin may also be involved. As you can see in the first picture, it shows bullae on the skin, and the second picture shows bullae on the oral mucosa. And the oral lesion may begin as vesicle or bullae, which can be identified clinically. The bullae could rupture and leave the large, superficial, ulcerated and denuded oral mucosa. It is painful and persists for weeks if it is not treated. And then the ulcer may also, it is seen diffusely throughout the mouth, but it may also be limited to a certain area, especially gingiva, and produce a clinical pattern which is called as desquamative gingivitis. Next, there is also ocular involvement. It started as subconjunctiva fibrosis, which then caused the conjunctiva to be inflamed and eroded. And then there is a scarring between bulbar and also palpebral conjunctiva, which caused the eyelid to turn inward. As the eyelid turns inward, the eyelashes will rub against the cornea and globe. The scarring also causes closing of the lacrimal gland opening, and cause dryness of the eye. As the protective mechanism, the cornea will produce keratin production, which eventually lead to blindness. The last stage of the ocular involvement is the adhesion between the upper and lower eyelids. As you can see in the picture, the upper and lower eyelid almost adhere together. If the bullae occur on the vagina mucosa, it will cause pain during intercourse. It is known as dyspareunia. And if the bullae occur on the laryngeal mucosa, it will cause airway obstruction. So, the histopathologic features is there is split between the epithelium and also connective tissue in region of basement membrane. And there is also mild inflammatory cells infiltrate in the superficial submucosa. And the direct immunofluorescence test, we produce a linear band of immunoreactants at the basement membrane zone, which consists of the IgG and C3. And indirect immunofluorescence also positive in the 5% to 25% of the patients. As you can see in the first picture, there is subepithelial split, and you can also appreciate the inflammatory cells infiltrate to the subjacent connective tissue. And in the second picture, there is a continuous linear deposit of immunoreactants at the basement membrane zone. Next is bullous pemphigoid. Bullous pemphigoid is the most common autoimmune blister condition, and it is characterized by the production of autoantibodies against the components of the basement membrane. It resembles mucous membrane pemphigoid, but the difference between bullous pemphigoid and also mucous membrane pemphigoid is bullous pemphigoid characterized by the periods of remission followed by relapse, while MMP is usually protracted and also progressive. Clinical features, it usually affects the older people, which is 75 to 80 years of age. There is no sex or racial predilection. The early symptoms, it presents as the pruritus, followed by development of the multiple tense bullae on the normal or erythematous skin. And it can cause, when the bullae rupture, it can cause superficial crust to form. And the healing will take place without scarring. As you can see in the picture, there's a bullae and also superficial crust. There's also oral mucosa involvement, but not all patients are being affected. It usually begins as bullae, but tend to rupture sooner compared to the skin lesions as a result of constant low-grade trauma to which oral mucosa is subjected. The rupture of bullae will cause large shallow ulceration with the smooth distal margin, as you can see in the picture. Next is the histopathologic features. There is a separation of the epithelium from the connective tissue at the basement membrane zone, result in the subepithelial separation. We can also see acute and chronic inflammatory cells, which can be seen in the lesion in all areas, and there is also presence of eosinophils within the bullae. Here is the characteristic features. in the bullous pemphigoid. So in this picture, you can see the subepidermal blister and also eosinophils in the blister. There is also eosinophils in the dermis. Next is the direct immunofluorescence for the bullous pemphigoid. There is a continuous linear band of immunoreactants, which is a IgG and also C3, which localize to the basement membrane. And the antibodies will bind to proteins that are associated with the hemidesmosome. Hemidesmosome is the protein of the basement membrane. And this protein are bullous pemphigoid antigen, which are BP180 and also BP230, which are located at the lamina lucida of the basement membrane. And the indirect immunofluorescence test which will reveal the circulating antibodies in the serum, which are IgG and also C3. Next is lichen planus. Lichen planus is a chronic immunologic inflammatory mucocutaneous disease which affect the skin, mucous membrane, nails, and hair that are vary in appearance from keratotic, which is reticular or plaque-like, or with erythematous and ulcerative. The lichen planus is derived from the word lichens, which are primitive plants that are composed of symbiotic algae and fungi. And the planus is a Latin word which means flat, and this is because Erasmus Wilson thought the skin lesions of the lichen planus look similar to the lichen which are growing on the rocks. Next is the clinical features. It usually affects the middle-aged adults and it has female predilection. The skin lesions, which are presented as purple pruritic polygonal papule, which can be seen as in the first picture, and it also usually affect the flexor surface of extremities, and there is also presence of fine lace-like network of white lines, which are Wickham's striae, on the surface of the skin papules, which can be observed as in the second picture. And the other extraoral sites is it can affect the glans penis, vulvar mucosa, and also nails. And there is three distinct form of oral lichen planus, which is the first one is the reticular lichen planus. It is the most common form and it is asymptomatic. It involves the posterior buccal mucosa bilaterally. It can also affect other oral mucosa such as the lateral and dorsal of the tongue, gingiva, palate, and also vermilion border. The post-inflammatory melanosis usually accompanies the reticular striae in the presence of color, and then the characteristic pattern is the interlacing white lines, which is the Wickham's striae. As you can see in the first picture, there is a post-inflammatory melanosis, and the second picture, you can see the Wickham's striae in the buccal mucosa, on the buccal mucosa. Next is the erosive lichen planus. It is symptomatic and there is an atrophied erythematous area with the central ulceration. And the periphery of atrophied region is bordered by white fine radiating striae, and the atrophy and ulceration can also be confined to gingival mucosa, which produce a clinical pattern which is called as desquamative gingivitis. If the erosive component is severe, the epithelial separation can be occur, and this result in the bullous lichen planus. Next is the as you can see, the first picture shows the central ulceration and the erosive lichen planus on the buccal mucosa, and you can also see the lichen planus on the tongue. Next is the plaque lichen planus. It appears well circumscribed, elevated white lesion which resemble leukoplakia, and it is most common seen on the tongue, and it produces irregular white smooth area and raised plaque. You can see the plaque form of lichen planus on the buccal mucosa as in the picture. Histopathologic features. It has a varying degree of autokeratosis and parakeratosis, and the rectal ridges have pointed or sawtooth shape. there is also hydropid degeneration of the basal cell layer of the epithelium, and there is also intense band-like infiltration of the inflammatory cells, especially T lymphocytes subjacent to the epithelium, and there's also degenerating keratinocytes, which are civet bodies. As you can see in this first picture, you can see intense band-like infiltration of the inflammatory cells, and you can also see the sawtooth shape of retinal ridges. In the second picture, you can see the hydropid degeneration of the basal cell layer, and also intense inflammatory cells to the subjacent connective tissue. The next picture is you can also see in the first picture, you can see the hydropid degeneration of the basal cell layer, and you can also appreciate the inflammatory cells. And then the second picture with the arrow shows the degenerating keratinocytes, or known as civet bodies. Next is the immunopathological features of the lichen planus. There will be deposition of the fibrinogen at the basement membrane zone and in the shaggy band pattern, as you can see in the first picture. And the second picture reveal the higher magnification. You can see the shaggy band pattern. And this is the Socratic code for our seminar, and it is our references.